Hi, this is Fawzia Rain, your host from PAPANA Mental Health Awareness Program. PAPANA, the Pakistani American Psychiatric Association of North America, is a non-profit organization. One of our major goals is to provide mental health care information and resources to the Pakistani community in the US as well as in Pakistan. In this regard, we are doing a series of webinars, lectures, and presentations. We appreciate the time you spend with us watching and listening. Today is our second lecture on the topic of cannabis, understanding its science, role in medicine, and risk-benefit analysis. We are truly honored to have this lecture series by an expert in the field of addiction medicine, a dedicated human power from the community, Dr. Samoon Ahmed, who also has conducted the first lecture on this topic last month, and you can watch it on our PAPANA YouTube channel. Now, I would like to invite Dr. Samoon Ahmed to start his presentation.
Thank you so much for your kind words. It's a pleasure to be here. Good afternoon. My name is Dr. Samoon Ahmed. I'm a clinical professor of psychiatry at NYU Grossman School of Medicine. And last year, I retired from post as unit chief of the inpatient unit at Bellevue Hospital, which is where I had the pleasure of working for over 30 years and currently practice at the Integrative Center for Wellness, which I founded in 1996. I have no conflicts of interest to report in terms of the lecture today. During the last session, I spoke about cannabis regulations, some of the biological constituents of cannabis sativa, and the basics of the endocannabinoid system, or ECS. Now, for those of you who are new to cannabis science and missed the first lecture, it might be a good idea to watch the previous session before viewing this one. As today, I'm going to focus on the ECS's activity in the central nervous system, or CNS, and what, if any, therapeutic promise cannabis holds in the field of neurology. In the next and last session, I will focus on cannabis and psychiatric disorders. So here's a roadmap for today's presentation. We'll start with a brief reminder of the receptors and ligands that make up the ECS, as well as how signals are sent within the ECS. We'll also go over the basic constituents of cannabis. And then we'll move on to how the ECS is believed to function within the central nervous system, including its activity in astrocytes, microglia, and oligodendrocytes. And then what some of the data says with respect to cannabis and the treatment of several neurological conditions. Now, in some cases, as with epilepsy, there is a good deal of evidence to present. Similarly, with diseases that appear to have a neuroinflammatory component, specifically demyelinating diseases like multiple sclerosis and Parkinson's disease, there's also a fair amount of data. Now, with respect to traumatic brain injury, Alzheimer's disease, dementia, amyotrophic lateral sclerosis, some other motor neuron diseases, as well as Huntington's disease, migraines, cluster headaches, obstructive sleep apnea, and Tourette's, there's significantly less data. However, despite the minimal data, there is hope that cannabis may at the very least alleviate some symptoms associated with these conditions. And this sense of optimism springs from a growing understanding of the ECS and its role in the central nervous system. Now, just so everyone is back on the same page, the endocannabinoid system, or the ECS, is a wide-ranging biochemical communication and regulatory system that is found throughout the body. While it is primarily found in the CNS and the peripheral nervous system, as well as the immune system, the ECS interacts with virtually every organ system among vertebrates. It is composed of receptors, ligands, known as endocannabinoids, and enzymes that synthesize as well as catabolize these ligands. There are two primary endocannabinoid cannabinoid receptors, CB1 and CB2. Now, the CB1 receptors are found in the central nervous system, particularly in areas of the brain that are associated with memory, thinking, pleasure, time perception, appetite, coordination or locomotion, as well as pain perception. While CB2 receptors are found primarily in the immune system, but I would say also throughout the body, as this slide shows. Now, in addition to these two primary receptors, there are two primary ligands within the endocannabinoid system. The first one is N-erectonyl ethanolamine, which is AEA, also known as anandamide, comes from the word Anand in Hindi, which Sanskrit, which stands for bliss, and 2-erectonyl glycerol, or 2-AG. The endocannabinoids 2-AG and anandamide are now produced on demand. In this slide, as this illustration shows, anandamide's primary precursor is N-erectonyl phosphatidyl ethanolamine, and for our purposes, we'll just call it NAPE. While the 2-AG is synthesized when diacylglycerol, or DAG, is hydrolyzed by DAG lipase. In addition, 2-AG is then broken down by monoacylglycerol lipase, and anandamide is broken down by fatty acid amide hydrolase, or FAH, which is actually quite important, and we'll talk about it. What's important to observe here is that ECS signaling is retrograde in nature. Now, which is contradictory, I think, as physicians, to our conventional understanding of neuroreceptor activation. Receptors are located, in this case, on the presynaptic neuron and receive signals from the postsynaptic neuron. Activation of presynaptic CB1 receptors decreases the intracellular signaling ions, which are required for release of excitatory neurotransmitters like glutamate, dopamine, and acetylcholine from vesicles in the presynaptic neuron. Activation of the CB2 receptors, meanwhile, decreases the pro-inflammatory cytokine signaling. And this really points to the central purpose of the endocannabinoid system, which is to behave like a dimmer switch, like a braking system for some of these other signaling networks. And through this mechanism, reduce phenomena like excitotoxicity or inflammation, and eventually promote hemostasis. Let me say this at the outset. This tidy depiction of the ECS is admittedly a bit of an oversimplification. There are CB2 receptors within the CNS outside of the neuroimmune system, and they play a role in the activation of GABAergic and inhibition of dopaminergic transmission in the ventral tegmental area, or VTA. Similarly, CB1 receptors are also expressed in the immune system, but the expression levels of CB2 receptors in immune cells is significantly greater than expression levels of CB1 receptors. Similarly, the boundaries of the endocannabinoid system are not just restricted to these just two receptors and two ligands. There's a host of other receptor sites that play a role in the endocannabinoid system, and this more expansive system is known as the endocannabinoidome and includes transient receptor potential channels, which are like TRP1, TRPA1, and TRPM8. Then there are peroxisome proliferator activated receptors. There is even serotonin receptors, dopamine receptors, opioid receptors, and I think the important one is orphan G protein coupled receptor called GPR55 and GPR18. In fact, several researchers have now proposed that GRP55 is not just a part of this endocannabinoidome, but should actually be considered a third cannabinoid receptor, and that it may play a role, in fact, in inflammation and even seizures. And I'll touch more on this momentarily. Many of the compounds found in cannabis very closely resemble the endocannabinoids found in the body and activate the ECS. Some of these compounds, like delta-9 tetrahydrocannabinol called THC, which is the cannabinoid that is primarily responsible for the intoxicating effects associated with cannabis, they directly interact with the CB1 and CB2 receptors. Cannabidiol, which is CBD, meanwhile, interacts in a more indirect manner. Example, it can moderate the THC's its effect on the CB1 receptor. It has been shown to inhibit what I mentioned earlier, the fatty acid amide hydrolase, which breaks down the endocannabinoids like anandamide. So consequently, what will happen? The anandamide will stay at an elevated level for prolonged periods of time, which has some potential medical benefits. It has shown agonistic activity at serotonin receptor 1A and dopamine receptor D2. And it has demonstrated antagonistic activity at GPR 55. And therefore, it disrupts the signaling of the lysophosphatidylcholine inositol, or LP1, which drives the GPR 55 mediated calcium signaling in the central nervous system. And it has an overall pro-excitatory effect. In fact, researchers at NYU recently published a paper showing that this disruptive effect on the LP1 signaling may reduce the frequency and severity of certain kinds of seizures. Now, other compounds such as terpenes, which give plants their scents, their aroma, and flavors, also indirectly impact the effects of THC by interacting with the transient receptor potential channels or some other receptors. And this results in what is known as the entourage effect, which I will talk a little bit more detail next time. And it's the reason why different cultivars or strains, as they're commonly referred to, produce different therapeutic and subjective effects, particularly stress relief. Now, important thing is this is not only subjective stress. The ECS also plays a crucial role in regulating stress signaling pathways. When the body experiences cell damage relative to oxidative stress, nitrative stress, infection, or any other insult, the result is an increase of pro-inflammatory cytokine production and leukocyte recruitment. And this is necessary. Why? Because it prevents the cell and mitochondrial damage, endoplasmic reticulum stress, lipid peroxidation, even tyrosine nitration, abnormal calcium handling. So following this pro-inflammatory phase is a resolution phase, where the anti-inflammatory cytokines and specialized resolving mediators, which are called SPM, and they include resolvins and medicines, restores the system to homeostasis. Now, as much as inflammation has become I would say, a dirty word within the field of medicine, whether it's heart inflammation, kidney inflammation, neuroinflammation, or I think the infamous cytokine storm that caught the media's attention during the start of the COVID-19 pandemic, it is a part of a larger dynamic balance that is necessary to keep us healthy. Because without an inflammatory response, we would not be able to clear the body of pathogens, damaged cells, and irritants. However, inflammation can become problematic when the system of dynamic balance between dysregulated and the inflammatory response is either overactive or inappropriately targets the body's own tissues and what's known as famously autoimmune disorder. So the result is an increased inflammatory response, the proliferation of pro-oxidant proteins, and sort of a vicious cycle that propagates the systemic inflammatory response, oftentimes without the participation of any external pathogen. And if it is allowed to continue unabated, the systemic inflammation can make the blood-brain barrier more permeable to the passage of these pro-inflammatory cytokines, leukocytes, and macrophages. And in the presence of this persistent insults, this can lead to the immune cells, I should say, of the brain, which are the microglia, to polarize into these active states. And the persistent inflammatory stimuli can lead to the activated macroglia to release inflammatory cytokines, these mediators recruiting even more immune cells. And when this is uncontrolled and prolonged, then the neuroinflammatory response can result in neuronal and oligodendrocyte damage. And in fact, there is some mounting evidence that neuroinflammation is at the core of the pathophysiology of neurodegeneration and multiple neurological disorders. Of course, the body has multiple systems that are designed to prevent or mitigate this runaway inflammatory process, and the ECS is, I would say, but one of them. However, and it's important, it represents a major therapeutic target to promote hemostasis. And this is why there has been such a enormous amount of interest in cannabinoids recently. It's also important to remember that many of these cannabinoids, particularly CBD, but also cannabidiol, cannabidiol, cannabiochromine, also have anti-inflammatory effects, but do not produce the kind of intoxication that is associated with THC and marijuana. So at this point, most of you might be thinking, well, this is all well and good, but what does the clinical evidence say? So, let's start with epilepsy. The anecdotal evidence of cannabidiol, CBD's efficacy as a treatment for seizure disorder, and particularly for epilepsy syndromes like the Lennox-Gastaut or Dravet and recently tuberous sclerosis, began to really emerge a little over a decade ago before becoming publicized by Dr. Sanjay Gupta's Cannabis special on CNN. The Lennox-Gastaut and Dravet syndrome are rare forms of childhood epilepsy characterized by drug-resistant seizures. Now, since the CNN special, multiple studies have examined the effects of CBD on these two forms of epilepsy. And for all of you, this is a very important point that this was not just a CBD they're talking about that was picked up by the nearby bodega or bought on the street. This is a purified formulation of cannabidiol developed by GW Pharmaceuticals and known by the brand name Epidiolex. Now, let's talk about some studies here. In one of those studies, the results of which are, you can see on the left side of the slide, those who received Epidiolex were given a dose of 20 milligrams per kilogram daily. So it's not the dose that usually you see people taking, it's a hefty dose, and then for 14 weeks, and saw a 44% decline in monthly drop seizures, while the controls had only a 21.8% decline. Now, a similar percentage of each had a 50% or greater decline in drop seizure frequency. And while the adverse events were common, I would say most were mild or moderate, and the most common being diarrhea, somnolence, fever, decreased appetite, and vomiting. The Devinsky study, and Oren Devinsky is one of the professors of neurology, in fact, at NYU, and he did this study, which is shown on the right side, which shows quite similar results. The 10 and 20 milligram groups experienced more than 37% and 42% decline, respectively, while the control group, only experienced a 17% decline. Similar to the earlier Thiel study, the most common adverse effects were, again, diarrhea, decreased appetite, and somnolence. And the adverse events obviously were more frequent in the 20 milligram group than either the 10 milligram or the controls. I would add that one of those adverse effects was elevated liver aminotransferase concentrations of 3 times the limit of the normal range, which is why it is vital to monitor liver enzymes should you decide to prescribe Epidiolex. And I think most clinicians should pay attention to this fact that the risk is higher when used in combination with valproate. It is important to have a baseline liver enzyme test and then subsequently monitor it at intervals like, I would say, 3 months, 6 months, or 9 months. And in addition to taking, valproate, when given the clonazepam with CBD, it can lead to some more pronounced side effects such as dizziness, drowsiness, and confusion. And this is even true for over-the-counter preparations of CBD too. So I think many of these patients, they're taking CBD. It's very important to ask about particular formulations they're taking, what dose they are taking, and it's important to monitor liver enzymes and to discontinue use if you see more than 3 times normal elevations of aminotransferases. Now, for Dravet syndrome, the results were similar, though patients were given Epidiolex in addition to their medication regimens, and this saw a drop of monthly seizures from 12.4 to about close to 6, while the placebo group only saw a decrease from 14.9 to 14.1. Very significantly, about 5% of the Epidiolex group became completely seizure-free, while none of the placebo group did, which I think speaks volumes about this issue. Now, following these studies, the oral solution of Epidiolex was approved for use by the FDA, and dosing parameters can be seen on this slide right now that's in front of you. I'd like to note that despite some adverse reactions, the effects of Epidiolex extend beyond the seizure reduction. The real-world data from a paper that was published in December of 21 found that in a majority of patients, in addition to both reducing the seizure severity as well as frequency, they also reported a host of other benefits, as noted on this slide. And this is just one example from a real-world survey involving 428 caregivers. But I think it aligns with this anecdotal reports about improvements in the quality of life issues for those who use cannabis, and in this case, particularly cannabidiol CBD. I'll be discussing the potential psychiatric applications of cannabis in more detail in the next presentation, but I do want to stress that CBD, which does not produce intoxication, helps to manage symptoms that are often seen as secondary to the primary disease. And as you can see on this slide, patients slept better and overall they feel better, and all with a relatively low risk of complications. Anyway, moving on, let's take a look at the multiple sclerosis. I should note that though cannabis may be effective at treating other demyelinating diseases, there has been far more research on how cannabis can be used to treat MS specifically. Now, just a few words on the pathology. The underlying pathology of MS involves oligodendrocyte apoptosis and the targeting of oligodendrocytes by immune cells. The cause of this dysfunction has yet to be elucidated, though there is some surprisingly strong evidence that it may be caused by complications following the Epstein-Barr virus infection. Anyway, regardless of what causes it, symptoms include fatigue, numbness, weakness, as well as tingling sensations. And in more advanced cases, symptoms can include neuropathic pain and spasticity. And all of this can have, again, a tremendous impact on the quality of life. Like other demyelinating diseases, autoimmune diseases, as even traumatic brain injuries, there is a bit of a snowball effect as increased cytokine signaling worsens this inflammation and symptoms, including neuropathic pain. Now, this slide, I have to admit, is a fairly busy slide, but I think you can see that the infiltration of the blood-brain barrier in step 1 leads to an innate immune response and activation of the microglia, and so on until the immune response leads to demyelination and oligodendrocyte apoptosis. The hope is that with cannabis-based medicines, we may be able to control this process from multiple angles. Now, first, the activation of the ECS would suppress, as we had discussed before, inflammation throughout the body, including the CNS, where neuroinflammation leads to demyelination. It would also suppress T cell proliferation and leukocyte recruitment. Next, cannabis-based medicines may reduce blood-brain barrier permeability, and that can help to prevent penetration into the central nervous system by leukocytes, which only, as we know, exacerbates neuroinflammation. Research has found that CB2 receptors are expressed in low numbers in endothelial cells across the blood-brain barrier when under hemostatic conditions. But that expression of the CB2 is increased during neuroinflammation to ameliorate and slow this disease progression. Moreover, the CB2 agonists introduced in vitro have been found to reduce the endothelial cells of the blood-brain barrier, thereby reducing this permeability and suppressing the expression of two of the intracellular adhesion molecule and vascular cell adhesion molecule called ICAM1 and VCAM1. And this is done in cultures. Finally, targeting the CB1 and CB2 has been shown to result in exon preservation And perhaps more importantly, I should say, within the context of multiple sclerosis, remyelination by promoting this oligodendrocyte precursor survival, proliferation, migration, differentiation, and then maturation. Now, the important thing is that this is not just theoretical. In fact, there is some clinical evidence to support the use of cannabis to treat multiple sclerosis. Nabiximols, which is an oral mucosal spray, again developed by GW Pharmaceuticals, that contains a formulation of THC in a CBD in a ratio of 1:1, and it's sold in about 25 countries under the trade name Sativex. Though it's in the United States, it's still in phase 3 trials and is indicated for spasticity, neuropathic pain, actually overactive bladder, and some other symptoms associated with MS. Out of the 5 randomized, double-blind, placebo-controlled trials of nabiximol, 3 actually demonstrated clinically significant reductions in spasticity, while the 2 showed no difference from placebo. I would say, these are good but not great results that could go beyond MS and apply to other conditions with neurogenic symptoms. Now, in fact, a Belgian study that was published in 21 found that was an effective add-on treatment, and that self-reported spasticity scores dropped significantly over 12 weeks, and these effects were sustained even after 6 and 12 months of treatment. And what I found particularly interesting in this study was that the symptom reduction was only part of the story. Quality of life scores saw significantly improvement as well, with the mean scores, but quickly increasing and then being sustained. And after 12 months, scores were still about 65% above baseline. So, is this a revolutionary treatment? No, of course not. Will it cure MS? No. However, there's a theoretical explanation for how it can stem the progression of the disease. And there is clinical evidence indicating that it increases patients' quality of life by reducing symptom severity. Furthermore, should a patient experience one of the relatively minor adverse reactions that were reported in the Belgian study, I would say they can simply discontinue use without having to wean themselves off the drug or undergo any kind of physical withdrawals. So now with the Parkinson's, the pathology of the disease is centered on nigrostriatal dopaminergic innervation and a consequent plummeting in the dopamine production, resulting in what we know as tremor, rigidity, and bradykinesia. However, additionally, there are non-motor symptoms that are important and characteristic of Parkinson's, and they include loss of appetite, pain, even nausea, anxiety, and stiffness. And there are at least 3 reasons, I would say, why researchers have been interested in the use of cannabinoids to treat Parkinson's symptoms. First, CB1 receptors are highly expressed throughout the basal ganglia and the subthalamic nucleus and can inhibit the release of glutamate, which has been implicated as a potential cause of dopaminergic neuron apoptosis in Parkinson's via glutamate excitotoxicity. And as I mentioned before, CB1 receptors are activated by sort of a reverse retrograde signaling from postsynaptic to presynaptic terminals. And why? So that they can inhibit the release of these excitatory neurotransmitters, and most notably being the glutamate, and thereby they suppress this excitotoxicity. Now, in an animal model, the synthetic cannabinoid called WIN55-212-2, which is a full agonist at CB1, it really significantly decreased the drug-induced tremors following the administration of biquiculline. And as we can see from this middle figure on the slide, the firing rate drops significantly following the administration of WIN55. And in the bottom figure, you can see that the rate should back up following the administration of the CB1 antagonist. So what does that indicate? That the tremors were mediated by activity at the targeted receptors. Now, second, a preclinical study by Carlsen and colleagues, which was published in March of 21, found that the intrathecal injection of WIN55 into the ventral horn of the spinal cord reduced the tremors via activation of cannabinoid receptors in these astrocytes. So the conclusion by the authors was that upon CB1 receptor activation, spinal astrocytes, they function as these filters that suppress this excessive neuronal rhythmicity by inhibiting the excitatory transmission. Third point, that the activation of these glial CB2 receptors with cannabinoids is also shown to reduce neuroinflammation globally in the CNS. And as neuroinflammatory cascade is believed to be a feature of the pathogenesis of Parkinson, some researchers hypothesize that cannabinoids could be used either as a therapeutic agent or as a means, I should say, of arresting the progression of the disease. A similar hypothesis is that the antioxidant properties of cannabinoids mediated through not only CB1 and CB2, but sort of a more expensive, what I mentioned early, the endocannabinoidome could help with symptom management and potentially to slow disease progression. So this could lead, could be a key to disrupting the disease pathophysiology, which is defined by this vicious cycle of oxidative damage. You can see on the slide, pro-inflammatory cytokine signal amplification. There is cell damage and apoptosis that spreads to these healthy cells and ultimately leads to neurodegeneration. In other words, the cannabinoid treatment, it would not prevent the inflammatory stimulus or change in the microenvironment, which is highlighted in magenta on the slide, but it could slow the progression and ease symptoms by suppressing the cytokine signaling and then decreasing the levels of intracellular reactive oxygen species known as ROS. Now, as promising as all these theories and preclinical studies may sound, the clinical evidence to support them is not especially strong, I should say, yet. Looking at some studies, a meta-analysis published recently by Irby and colleagues did not find particularly strong evidence to favor the use of cannabis. It may help with tremors, as well as levodopa-induced dyskinesia, but importantly, its real benefit appears to be as an add-on treatment for non-motor symptoms, such as anxiety, pain, and sleep problems. So once again, what we see is that cannabis use seems to have an extremely positive impact on the quality of life. And this is something that was supported, in fact, by the Parkinson's Foundation in a bulletin that was released in 2021, titled Consensus Statement on the Use of Medical Cannabis for Parkinson's Disease. And in this, while they urged caution with respect to recommending cannabis and expressed some concern about adverse effects and drug-drug interactions, they did actually acknowledge that many patients are reporting that cannabis helps with these non-motor symptoms. And in fact, a survey which was done by Feeney and colleagues provided further evidence that this is the case. They found that very few patients experience worsening symptoms, and a few experience, while no improvement, majority saw improvement in symptom severity and frequency, which had a very clear positive impact on the quality of their life. So to recap, those are the three conditions where we have the most data. But, just to change, track, I would like to mention a few others, though the details are limited and the data is not as strong. For example, there's a very promising preclinical evidence suggesting that ECS may be able to mediate glutamate excitotoxicity following TBI, traumatic brain injury, via mechanisms which I've described above. Additionally, the neuroprotective properties of cannabinoids may aid patients in recovery, particularly, I would say, if they're administered very quickly following an injury. However, any clinical evidence either in support or against the use of cannabis to treat TBI, in fact, does not exist yet. Now, with Alzheimer's disease, the case is similar. The preclinical evidence suggests that ECS plays a role in many of the pathological processes involved in the disease and other forms of dementia, including neuroinflammation, mitochondrial dysfunction, oxidative stress, and protein misfolding. Additionally, the activation of CB2 receptors may promote the removal of beta amyloid plaques by macrophages. However, clinical evidence to support the use of cannabis to treat Alzheimer's is still lacking. And at this point, though, some studies have found that dronabinol, which is a synthetic analog of THC, at relatively low dosages of between 2.5 and 5 milligram, it can treat anorexia and even agitation without significant side effects. However, non-randomized clinical trial evidence also suggests that cannabis may help with symptoms associated with motor neuron disease like amyotrophic lateral sclerosis, particularly the neuropathic pain associated with cramping. But the sole RCT evaluating cannabinoids as a treatment for ALS did not produce clinically significant results after 5 milligram dose of THC, which was administered twice daily for 2 weeks. That said, an RCT evaluating the effects of nabixamol, as I mentioned earlier, the Citivex, which is the formulation developed by GW Pharmaceuticals and contains a mix of THC and CBD in a 1-to-1 ratio on motor neuron disease, including but not limited to ALS, it did produce a positive effect on spasticity symptoms over the 6-week trial, though I should say most outcomes were not clinically significant, even if the treatment was well tolerated. Evidence from some non-RCTs suggests that cannabis can help with symptoms associated with Huntington's. And a literature, in fact, review found that THC may help with spasms, tremor, chorea, sleep difficulties, and pain. But again, no RCT has yet shown a difference between medical marijuana and a placebo. And in fact, a single 5-week pilot study involving 1 milligram or 2 milligram dose of nabilone, which is actually a scheduled 2 synthetic analog of THC, showed a modest decrease in chorea compared with placebo. The same can be said of migraines and now cluster headaches, that, some patients say they have experienced symptom improvement, but this again has not been documented using objective measures. There is also some worry that any reduction in pain due to the administration of cannabinoids may lead to rebound headaches. Now, for obstructive sleep apnea, dronabinol has shown some promise, interestingly. The Carlsen and colleagues found that both 2.5 and 10 milligram doses of dronabinol were well tolerated, and that those in the 10 milligram group had the highest satisfaction with treatment. And additionally, dronabinol was associated with lower apnea hypoxia index and improved self-reported sleepiness, though the treatment did not affect gross sleep architecture or maintenance of mean sleep latency. Now, despite these findings, it is important to remember this, that the American Academy of Sleep Medicine issued a statement in 2020 advising against the use of marijuana or dronabinol, because they said until there is sufficient scientific evidence of safety and efficacy. So finally, we'll talk about Tourette's. A small RCT study has found that some patients report reduction in tics and obsessive compulsive behavior by using THC at doses of about 10 milligrams over 6 weeks, while a single dose trial of THC also showed improvements in both tics and obsessive compulsive behavior. Meanwhile, anecdotal evidence suggests that CBD can also ameliorate stress and anxiety, which again, has been shown to trigger increases in tics. More recently, a small open-label prospective study was conducted that involved only 18 participants. And while the reductions in tic severity and urge for tic scales were modest, what really stands out is the improvement in patients' quality of life. 92% of these patients were satisfied with the treatment's effect on quality of life after 12 weeks, including 21% who were quite satisfied. Now, this is what we see time and time again. Cannabis is not the panacea that it's said to be, but it does offer relief to many patients who are struggling with quality of life issues and difficult to manage symptoms. And living with these kind of symptoms is psychologically taxing, especially, I should say, when debilitating symptoms seem to come and go without explanation, as is so, often happens with neurological disorders. It can really saps one's motivation and, in fact, open the door to depression and bad habits that, as we know, begin as self-medication, ultimately can become substance use disorders. Now, I want to be clear that cannabis does not eliminate every symptom that the patient may be experiencing, but it can make them more manageable for some patients. And for many patients, this is like a liberating experience. Cannabis offers them the opportunity to mitigate their symptoms, typically, I should say, without severe adverse effects or very high risk of dependency, with a caveat, which is one reason why it has become so popular. It should be noted in all clinicians that just because the risk of dependency is low, it does not mean it does not exist, especially in younger patients and those with predisposition for some psychiatric conditions or have a family history of such disorders. Moreover, this risk varies from patient to patient and should be a part of the discussion and decision-making process. So, in summary, we are what I call as a transitional period with respect to cannabis. In addition to existing in a sort of a legal gray area with respect to recreational and medical use, research is also at the same time in a gray area because, there is abundance of anecdotal reports and preclinical or observational papers, but a paucity of high quality studies. And as the notion that cannabis is devoid of medicinal use is abandoned, and as regulations ease up, I think it is my hope that we'll begin to see more randomized, double-blind, placebo-controlled studies, which are the hallmark of scientific evidence, to better evaluate the potential uses and risks of cannabis for numerous neurological indications. And I expect, in the next 5 to 10 years, in cannabis science to be really, truly thrilling. So with that, having said that, I would like to end, and I hope that this information has been helpful, and look forward to our third and final lecture, which will focus on mental health issues. So thank you for watching or listening.
Okay. Thank you very much, Dr. Samoon, for this comprehensive lecture on the mode of action of THC and all the risk and benefits. And we are looking forward for the third lecture. I have a question that I completely agree with you that the subject of cannabis is currently overwhelming for doctors. And they often lack the tools to speak in detail about the potential risk and benefits of medical cannabis with their patient. But the point right now, the war currently is how to differentiate between the medical cannabis and the recreational cannabis, because right now the major war is against recreational cannabis, and whoever the doctor is prescribing, they are always worried about the potential risk of addiction.
Well, the point is, in fact, that if you look at, I'm going to make an analogy, that in the states where cannabis is legal, in fact, you have seen a decline overall in the opioid use of many patients. So, you can, and the data is being gathered. There are some conflicts, but overall, in fact, it has helped. And I think if the physicians are sort of well-versed in knowing the benefits and risks, and they can, as I mentioned, screen patients, particularly adolescent, young age, or older patients, look at their predisposition, look at what are the comorbidities, what are the risk factors in that way, and then can monitor. I think overall, you would see that the quality of life, when it improves, people tend to use within those guidelines rather than go for recreational use. And I think people go for recreational use or go for information on Dr. Google because they're not getting appropriate dosing strategies, monitoring, listening to their physicians who can provide them a very clear benefits and risk, and be able to not be judgmental about these factors. I think the best thing, as mental health from a perspective, we are the gatekeepers. People come and trust us with things that they wouldn't go to any other physician or talk about in that way. So we are the gatekeepers that way, and we can walk them through this fine line of make them understand what the risks mental health wise versus the benefits on the physical health being. And I think if you take that approach, you would see that the results are in fact quite positive in that way. And that's why I use the word low risk of dependency, which is sort of I would say contradictory to how most psychiatrists or mental health practitioners think of this, in that, because it has been brought under the umbrella of other drugs, like whether it's heroin, whether it's opioid, whether it's cocaine, whether other, which it's a very different kind of a drug overall compared to what we see with some of the other ones. So that's how I see it.
Very much. Another question is, you mentioned in the previous session that there are more than 100 cannabinoids found in the cannabis. But the discussion today, you have just focused on CBD and THC. Is research being conducted on other cannabinoids? And if so, what are some of the potential uses for those other compounds?
Well, great question, because you are absolutely right. We know there are about 140, and we really know about 120 or 30, 40 we don't even know much about. And the most everybody talks about is THC and CBD at this point. And I would say the research into other cannabinoids is ongoing. And the one that seems to be, if I have to pick one, show the most therapeutic promise is cannabidiol, which is the abbreviation is CBG for that. And just to give you a little bit of science behind it, the carboxyl acids of tetrahydrocannabinol, of THC and CBD, which are present in their highest concentrations when the plant material is just fresh and raw, also appears to be beneficial. But research into these compounds is still very early. The CBG, or rather I should say CBG acid, is the precursor of these carboxyl acids of THC and CBD. So when this CBG or cannabidiol is decarboxylated, you get cannabidiol, which shows activity at both cannabinoid receptors and other ones, serotonin 1A, alpha-2 adrenoreceptor, the peroxisome proliferator activated receptor, gamma, and several TRPV receptors, and capsaicin, which is the pain receptor. And in fact, in 2020, Nashani and colleagues, they published a paper highlighting a lot of the potential therapeutic uses of cannabidiol, finding that it may be beneficial as an add-on treatment for many of the conditions that I've covered today, including Parkinson's, multiple sclerosis, ALS, Huntington's, tic disorder, and even inflammatory bowel disease. And considering that I just mentioned as an alpha-2 agonist, which I think as psychiatrists, when we are concerned about stimulants use, we use them in patients with ADHD. So it can actually be used in that domain as well. So again, with a caveat, I would say all of this is based on preclinical models, but the clinical trials are in the process of being conducted at this point, and lots of, different teams and studies are being done and currently recruiting for these studies. And they will examine the CBG impact on appetite, pain, sleep, ADHD, inflammation, migraines, and we will begin to see these results. But as I think because of the legal issues, as well as clinicians being less informed and not going the way of the studies because of so many limitations, the double-blind placebo-controlled studies are very hard to come by of these cannabinoids. And that's been a major issue. But, as restrictions are lifting, I'm hoping that we will see actually a lot more on this.
Much, Dr. Ahmad, for this informative presentation on this topic. And I would say this is a critical topic of our times. Thank you very much, all our viewers, for your time. This was the second lecture on the topic of cannabis, and we will be coming up with the next one soon. We are confident that this information lecture series would be an invaluable resource for not only for physicians and residents, nurse practitioners, pharmacists, and other clinicians who seek reliable clinical guidelines in this growing area of the healthcare, but also for the general population to get educated about cannabis. Thank you very much.